Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of the following sponsors: Strongbridge, Biopharma, Pfizer, Novartis, and Ipsen. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors to bring valuable resources and programs for the patient community. Today's webinar title is Expect More from Pituitary Surgery, Difference Makers for Post-Operative Outcomes. Our expert presenters are Dr. Ahmad Sadagat, Associate Professor and Director of the Division of Rhinology, Allergy, and Anterior Skull-Base Surgery in the Department of Otolaryngology, Head and Neck Surgery at the University of Cincinnati College of Medicine and UC Health, and Dr. Norberto Andaluz, Professor of Neurosurgery and Otolaryngology, Head and Neck Surgery, Director, Division of Skull-Base Surgery, University of Cincinnati College of Medicine and University of Cincinnati Gardner Neuroscience Institute, UC Health. You can learn more about each doctor in the slide titled Presenter's Biography. The learning objectives of this presentation are to understand the surgical steps of endoscopic pituitary surgery, to understand how the surgical steps of endoscopic pituitary surgery translate to post-operative outcomes, to understand surgical factors that can modify post-operative outcomes after endoscopic pituitary surgery, and to understand the post-operative care that can modify post-operative outcomes after endoscopic pituitary surgery. On that note, there will be a brief pause while I switch presenters, and then the webinar will begin with our doctors. Thank you.
Well, good afternoon. This is Norberto Andaluz. I'm a neurosurgeon, and sitting next to me is Dr. Ahmad Sadagat, my rhinologist partner. We're here to talk about what makes a difference in postoperative outcomes in pituitary surgery. This is myself. This is Dr. Sadagat. We have nothing relevant to disclose. And really, we have myself as a member of the Pituitary Network Association. I have had the privilege of being a presenter before, and we thank the PNA again this year to be able to be presenting. And I have also had the opportunity to see other of the presenters that have been here through the years, really top-notch specialists, everybody well recognized on the field. And it is a little bit difficult to come with new topics, but there's really everything that has to be said about pituitary surgery has been said. However, what we would like to focus is more than just the procedure. I think that the technique has been mastered. This started more than 110 years ago with Dr. Cushing. Here's Dr. Cushing on a depiction, but later on a picture, this is Dr. Cushing operating in Harvard, which is where Dr. Sadagat completed his training. And truly, things have changed through the last century in the way that we have made this more effective, and outcomes have gotten better, and techniques have gotten better, and this is a procedure that has become fairly standard in many places. However, still, we're trying to focus beyond the procedure itself and trying to look into the things that make a difference in the outcomes of pituitary surgery. And so, trying to decompose what the procedure itself would be, you have to look into operative outcomes, and obviously we all want to accomplish total tumor resection. But there are other difference makers, and as always, things are in the details. The perioperative management, and that's where you start working with your colleagues, your partners, everybody in your team, the endocrinologist, sometimes the neuro-ophthalmologist, and obviously a big component of what makes the outcome in the post-operative period is the sinonasal quality of life. And then this is sadly sometimes brought to attention, and we learned the hard way in the past after the surgery is done. And in reality, I hope we can convince you that some of these things need to be looked at before the surgery in order to have a successful outcome. So we're going to be focusing mostly on the endoscopic pituitary surgery approach nowadays, because it's where the majority of the community has accepted as the most beneficial way of doing this surgery. However, I must say that I do have colleagues and friends who are extremely talented surgeons that prefer to still do pituitary surgery using the endoscope, and with really excellent and better results sometimes that many endoscopic surgeons. But still, this is what most everybody now is doing these days. And so, as I said, we want to look at surgery just beyond the surgery. The surgery itself has become something that most everybody can do, and it's become very safe. And so, how do we make patients better after surgery? What are the difference makers? That's what we're trying to focus on. So one of the things that we really learned through the years is what the partnership with your rhinologist can give you in terms of access. And I'm going to turn over to Dr. Sadagat so he can explain a little bit how some of the maneuvers and some of the evaluations that he can do before surgery can lead to a better outcome after surgery.
So, as Dr. Andalus discussed, really what's becoming the standard approach to pituitary surgery is the endoscopic approach through the nose to access the sphenoid sinus, which is the deepest sinus in the head, and this is where the pituitary sits. And by accessing the sphenoid sinus and opening that up, we give our neurosurgical colleagues access to the pituitary gland and any pituitary tumor within it. Endoscopic sinus surgery is a well-established surgery and has really developed over the years. We do this all the time for patients with sinus problems, sinus disease, and so some of us, for example, like myself, essentially this is the only surgery that we do, and getting access to the sinuses is really a very easy kind of thing to do. And so this is really the approach. These are some nice images for the approach to the sphenoid sinus where the pituitary is. Let's see. So I think everyone can see my arrow. So up here, this is a nice endoscopic view of the right nasal cavity. And in the nasal cavity, there are these structures that kind of stick into the nasal passageway called turbinates. This is the inferior turbinate. This is the middle turbinate. And the sphenoid sinus is kind of like in this cleft back here, really between the septum, which is this wall that separates the left side from the right side, and the sphenoethmoid recess, where the opening to the sphenoid sinus sits between the septum and another one of these turbinates that sits a little higher up. So as we advance a little further into the nose, again, you can see the back of the nasal cavity, back of the middle turbinate, inferior turbinate. And again, squeezing between that middle turbinate and the septum, you get this what's called the sphenoethmoid recess. And then going up a little bit higher, you see that other turbinate that I was talking about, called the superior turbinate, which is a little higher up and a little more posterior, a little further back than the middle turbinate. And between that superior turbinate and the septum is the opening to the sphenoid sinus. And if we look through this opening, you get this nice view of the interior of the sphenoid sinus. And this is the sella right here. And the pituitary is going to be right on the other side of the sella. And by opening up this sinus, so you can imagine that we can find this natural opening of the sphenoid sinus and just make it larger. And that would give great access to our neurosurgical colleagues to go in and then open up the cella and access any tumor that's behind it. So as Dr. Andalus alluded to, pituitary surgery has gone through a little bit of an evolution over time, naturally, as any surgery does. And one of the more recent approaches has been the microscopic view, where you can access that sphenoid sinus opening and then use a microscope to look through it. The endoscope allows us to really get much closer and get a much broader, simultaneously get a closer view, but also a much broader view, a much more dynamic view of the inside of that sphenoid sinus, where you can really get a good view of not only the cella where the pituitary is, but also the whole breadth of what's on the inside of the sphenoid sinus, so where the carotid arteries run, the roof of the sphenoid sinus, and really anywhere throughout here to really get a good view of all the boundaries, so you can take your surgery into any direction that you really need to. So endoscopic pituitary surgery really is the most recent step in terms of the evolution of pituitary surgery. And as Dr. Andalus mentioned, it's really becoming more or less the standard approach that many individuals are using. But you can imagine, as this transition and as this evolution has occurred, there have been studies, understandably so, to really try to understand whether this is the best way of doing it. And so the comparison has always been to using the microscopic approach to the pituitary to see whether the endoscopic approach is really the best next step. And so in terms of outcomes that we look at, again, as Dr. Andalus referred to, is we're talking about how much of the tumor can we get out? Can we get the whole tumor out? And then once we do get the tumor out, is there recurrence of the tumor? So there have been a number of studies on this, comparing again the endoscopic approach to the microscopic approach, and this is just an example of some data from one study where the red bars represent microscopic surgery, and the blue bars represent the endoscopic approach to the surgery. You can see up at the top, on the top panel, generally speaking, with the blue bars, you see a much greater degree of tumor resection. In the middle panel, you see with the endoscopic approach, there's generally speaking much greater rates of complete tumor resection. And then in the lower panel, again, with the blue bars, which represent the endoscopic approach, there is much less recurrence, so much higher controls of tumor control rate. This is another nice study. It was a systematic review, which essentially means a study of studies, where these authors took all of the different studies looking at the comparison between endoscopic versus the microscopic approach for pituitary surgery, in this case specifically for Cushing's disease. And again, looking at remission rates as well as recurrence rates. And what they actually found is that for small tumors, these two approaches were quite similar. But for larger tumors, what we call macroadenomas, tumors larger than a centimeter, the endoscopic approach had higher rates of remission, indeed getting the tumor out so that the Cushing's goes into remission. And then the endoscopic approach had much lower rates, much lower rates of recurrence for the large macroadenoma tumors. So, as Dr. Andalus described, pituitary surgery has become a very standard surgery, and a lot of great individuals, and Dr. Andalus is one of these visionaries and innovators who's pushed this field forward, have really described the ways to do this surgery the right way and the safe way. The question is going beyond that surgery and identifying how can we make outcomes even better beyond just safe surgery. So from some of the preceding slides, you can really see that in terms of difference makers, endoscopic surgery is a difference maker. It increases surgical visualization. And you've got a nice example of that in terms of comparing that. You've got a nice example of it on a subjective level, looking at the comparison between the microscopic view and the endoscopic view. But looking at the data from all of these studies that have been published now, we see again that with the endoscopic approach, we have much greater degrees of resection of tumor, much higher rates of complete resection of the tumor, and there's lower recurrence rates with the endoscopic approach as well. So from our standpoint, our feeling is that endoscopic surgery is one of these difference makers that takes a standard safe approach and it gives us better outcomes overall.
So I would like to echo some of the concepts that Dr. Sedaga just gave. And I think that, again, this is just beyond the standard endoscopic approach, which nowadays anybody can do. And he's downplayed a little bit the role that he plays in surgery. But certainly the way that the endoscopic approach is done, I think is that where the difference is. Because again, most everybody nowadays has learned how to do the endoscopic approach and has mastered it. But sometimes having a rhinologist that is dedicated to preserve the function of the airway, the nasal cavity and the sinuses, keeping that in mind when you're doing an approach, really does make a significant difference in the outcomes. You know, we have learned through the years that making an opening just as big as possible anywhere in neurosurgery in general doesn't necessarily translate with you being able to do a better job. And sometimes you just have to do whatever is right and enough to take care of the problem that you're dealing with, be it pituitary surgery or any other kind of condition in neurosurgery. And then going back to his concept about visualization, I'm a little bit older than he is, and so I learned how to do the pituitary surgery using a microscope. And really the difference is just, at least in my experience, was abysmal. The first time I did with my rhinology partner from back then, I never did a pituitary surgery through the microscope again. The difference being the visualization is really substantially better, in my opinion, and so is also the control of the field. You need to think that the source of light when you're using the microscope is several inches away from your target, whereas when you have the endoscope, you're just looking at it within just millimeters. And so that makes a significant difference in terms of visualization, illumination, and your ability to manipulate instruments. But then moving beyond the issue of endoscopic surgery and how it is done technically, there's other aspects that we've been looking into on what would make a difference. And so the logical question that we get from many patients, anybody that is sent to have a surgery, they will ask you, how many of this have you done? What's your experience? And so this had never been studied until more recently. And there's quoting a position statement from the Pituitary Society. So this is really not too many surgeons, mostly endocrinologists. And so they came with this criteria of definition for what constitutes a center of excellence in pituitary surgery. And they look specifically at whether the experience of not only the surgeon, but the center that is treating these patients, if their experience does make a difference. And then, yes, looking at the data, the answer was yes, there seems to be a difference in the outcomes, a positive difference. So you can go through the list. It says essentially that experienced pituitary surgeons tend to have better outcomes, that the workload of a surgeon is also associated with better outcomes, that in cities where there's fewer centers with fewer surgeons, things tend to turn out better. And then there's this controversy on what's the ideal number of pituitary surgeries that you have to do every year to be considered according to this criteria a center of excellence, and they came with this magic number of 50. That's a very debated argument, but clearly the information that we have seems to signal that the more you do, the more experienced you are, and obviously you're more likely to have better outcomes. here's more information. One of the big things that has been looked at in terms of outcome through the years is particularly with the introduction of endoscopic surgery. So one of the big arguments was the chances of having a cerebrospinal fluid leak. And one of the arguments against the use of endoscopes at the beginning was that there was higher rates of having a CSF leak for the patient, which, as many of you know, negatively impacts outcome because there's prolonged hospital stays, perhaps the need of additional procedures, there's higher risk of infection, there's more symptoms and longer recovery. So certainly that was a point of significant interest. But then yet, as time goes by with everything else, the more experience that the surgeon has become, the lower your chances of having a CSF leak they are if you're a patient. And here's a list of all the other complications. This is a very nice review, which looked at the chances of having a complication in relation to the experience of the surgical team. And you can see a ranking of all the complications, anywhere from the most simple to the most daunting, anywhere from carotid artery injury to death. And you can see that as the number of procedures are done, the rates of having complications also comes down. So it really seems to make a difference. So that is another difference maker. And like things in medicine these days, they have gone beyond what you normally see in television shows where there's a doctor that does everything. This is truly no longer a one individual effort. And so there's so many people, given the complexity of what entails the fact of having a pituitary tumor, there's so many people that nowadays should get involved in the management of these patients, that really having all your specialists aligned in any organized form of delivery of care really makes a difference. Anywhere from your preoperative evaluation, and it's interesting because many times we see patients who have had treatment elsewhere, and some of these steps are missing. Some have not had a full endocrine workup. Some have not been optimized before a procedure, and also there are aside from the procedure that may go well, some have not had a follow-up. They've been told that their surgery went well and they never had a follow-up, and 5, 6, 7 years pass by and the patient has a pituitary tumor again. It becomes to the patient a big surprise. So having a system of care that will accompany the patient from the beginning to the end certainly seems to have a difference, rather than having a fragmented care where you go one place, you get your MRI, the other place you get your surgery, and then you're kind of left on your own trying to find your own way to have a follow-up. And so, as we said before, this seems to beat again on the same points, where pituitary adenoma is just a complex condition. It's just not a simple tumor that goes beyond just having a surgery. And these are all the people that you really would like to have available. Are you going to use each and every individual of this? Absolutely not. However, if you're going to have this type of procedure, you might as well be prepared for anything that may go adversely. Hopefully you will never need to go to the neurocritical care unit or need a neuroradiologist or have an emergency carotid procedure, but certainly you want to have all the tools available and readily available in order to be able to provide the best outcomes. So for an example, this is one of the cases that I used as an example for many years, several years here in Cincinnati. This is not that recent, but there was a specific patient, it's a true patient story, who was diagnosed to have a pituitary adenoma by his optometrist, had to wait a certain time to go to his primary care doctor, and then, long story short, this patient had 7 appointments scheduled in a 3-month interval, seeing the primary care doctor, getting the MRI, seeing a neurosurgeon, then having to go see a rhinologist elsewhere. And then in the process, while he was recommended to have a surgery, he lost vision and ended up having emergent surgery. Whereas on the other scenario where you have all the specialties aligned, this is what typically happens nowadays in our center. You would be diagnosed by your primary care doctor, and everything happens essentially under one roof. So having the ability of have what we call the multidisciplinary clinics, where you can see your endocrinologist, your rhinologist, your neurosurgeon, and perhaps have let's say a study that you haven't had, like for example a CAT scan or an MRI, all on the same day, really does make a difference, not only for the sake of convenience, but also for the communications and the coordination of care that patients receive. So again, does that make a difference? Yes, it does. And again, we're moving a little bit behind or past the surgery after your procedure has gone well. Does an interdisciplinary approach make a difference? And does that not involve only just the best specialists? That's, you know, having dedicated nurses that know how to watch a patient, how to control a patient after the surgery for things that may ensue, such as diabetes insipidus, or changes in some of the endocrine or physiologic parameters that are associated with surgery. It's extremely important to have 24/7 in-house specialty coverage. Sometimes we treat very complicated patients with Cushing's disease that need frequent laboratory testing and replacement of hormones around the clock. It really does make a difference. And like I said before, management of complications, both the expectable complications, and sometimes, you know, if you do enough of surgery, you're going to have some unexpected complication. If you have all your needs lined up in case that you obviously hopefully won't need it, but use it, it really does make a difference. Follow-up, coordination of care, it really does make a difference. So patients leave the hospital and they know when their follow-up appointments would be, when their MRIs would be, where to go to get the labs. It's not like the case where you have to go home and start making phone calls to try to schedule an appointment with an endocrinologist, an appointment with a neurosurgeon, an appointment with a rhinologist, an appointment with a lab. And so that really makes a difference to, from not only from the service perspective, but also for the patient to be concentrated exclusively on recovering from surgery. And in the same line of being prepared for everything, talking about interdisciplinary approach, what happens if you know, we talked about endoscopic surgery as being nowadays becoming the preferred method. What happens if I'm not a candidate? And that may be for different reasons. Maybe mostly they're related to the tumor itself. Now, if you have a tumor that exceeds beyond the line of view that you can get, so what you see here shadowed cannot be reached by the endoscope. So really, with an endoscopic technique, you can you can treat pretty much everything on the area that is visible. But if you have tumor that exceeds that area, what do? Do you just take only whatever the endoscope can take? Well, of course not. And then that's where having available different techniques to treat these patients becomes also very important as part of being able to provide the best solutions. And so through the years, we have worked with our lab and with our anatomists and with our colleague rhinologists in different ways of accessing these tumors when they're not amenable to endoscopic treatment. And so we have also minimally invasive approaches where we can go in and treat tumors that are beyond the confines of what the endoscope can treat. And through small windows in the skull, we can still stay outside the brain, sometimes even to the point that we can do incisions through the eyelid. And this is my original description of the approach from a couple of decades ago now. And this is one of the first patients that we treated that way, where you cannot tell that this patient had had brain surgery, really. Used the standard blepharoplasty incision. This is the site where we did the surgery. So after you ask her to look down, you can see the difference. But otherwise, after she's recovered and all the swelling is gone, you really cannot see much of what's going on. And is everything surgery? Of course, not everything is surgery. If surgery was the solution to everything, we would not have problems. And so that's where having your radiation oncologist will help. There's sometimes where tumors are in areas where are hard to reach, or not necessarily by the aspect of being difficult to reach, but in the sense that perhaps the risk of leaving the patient with a problem bigger than the one they came with through a surgery is not the recommended way to proceed, and therefore that's when we treat these patients with radiation. And so this is one of the typical radiosurgery plans, where our radiation oncologists or sometimes neurosurgeons that are trained in radiation oncology can truly map this tumor and deliver appropriate degrees of radiation to the tumor without causing damage. You see some structures highlighted there, such as the brainstem and the eyes, which are the areas that they specifically take care not to harm through the delivery of radiation. And again, this is part of what we call the multi or interdisciplinary treatment of tumors. All these patients are discussed in our conferences and our tumor boards, and amongst the different participants, one from each specialty, we usually decide what would be the best course of action for these patients. So in terms of long-term outcomes, certainly recurrence is a problem, and this is one of the things that we have in mind before we do our surgery, so we make everything possible for that not to occur, and that's where we're prepared with things such as radiation and different modalities of radiation. And the other thing that we focus that are really a factor that affects the quality of life for many patients is the sinonasal symptoms and the chronic sinus problems. As a neurosurgeon, truly, I don't get to see, if the patients do well, I don't get to see them as much as my poor partner, Dr. Sadagat, because of all the problems that ensue with all the airway symptoms that they may have after surgery.
So Dr. Abelos gave a great description of sort of what we're thinking about during that perioperative period, during the recovery, during the short term after the surgery, and what are the kinds of difference makers we're thinking about and talking about with respect to maximizing patient outcomes and making sure that patients do well, feel good, and are happy and satisfied during the short-term and perioperative periods. But moving towards the longer-term outcomes after pituitary surgery, of course, recurrence of tumor is a possibility, but interestingly, sinonasal symptoms and chronic sinus problems, these are potential long-term outcomes, or I should say that whether these even occur, this is one factor that we think about in terms of long-term outcomes after pituitary surgery. And generally speaking, pituitary surgery does not decrease quality of life. Patients do well with pituitary surgery, but a number of studies have now shown that when quality of life is affected, is negatively impacted after pituitary surgery, it's generally due to sinus and nasal problems, which may be somewhat counterintuitive when you think about the fact that this is brain surgery. But at the end of the day, really, when this surgery causes negative impact on quality of life, is due to sinus and nasal issues. So when we think about long-term outcomes with respect to sinonasal problems, we're really thinking about avoiding those sinonasal complications, really to maximize our patients' quality of life. And this is something that I'm particularly biased towards, because My whole practice is devoted entirely to sinus surgery and to treating problems of the sinuses. So it is particularly, it's something that is particularly apparent to me, how much quality of life can be impacted by sinonasal issues. And so the kinds of sinonasal complications that have been described after pituitary surgery include decreased sense of smell, sinusitis, whether it is acute, these bacterial sinus infections, recurrent acute episodes of sinusitis, as well as chronic sinusitis, which may occur just due to chronic inflammation within the sinuses that arises after the surgery. And this can also be characterized, and patients may experience symptoms of scarring and crusting within the nose as well. So these are the kinds of sinonasal complications that we strive to avoid in terms of maximizing quality of life and long-term outcomes for our patients undergoing pituitary surgery. So decreased sense of smell can occur because those smell nerves that enter the nose enter through the cribriform plate all the way at the top of the nose, and they grow down both onto the septum as well as those turbinates that I showed you earlier in the figures. So they can grow onto that superior turbinate that's right next to where the sphenoid sinus opening is, and they can grow onto the top of those middle turbinates as well that we have to pass by to get to the sphenoid sinus. So, of course, because manipulation of the superior and middle turbinates may occur during pituitary surgery, this can affect sense of smell. Sometimes we have to raise a flap of mucosa from the septum in order to patch the skull base defect at the end of the surgery. This is called a nasoseptal flap, and that could potentially affect those smell nerves as well. So it's been shown, and we've found the difference makers in terms of minimizing the loss of sense of smell to essentially zero is simply being aware of the anatomy and the physiology and understanding where those smell nerves are projecting down onto the olfactory epithelium within the nasal cavity, on those superior turbinates, on the middle turbinates, on the septum. And as we do this dissection, whether I'm doing it for patients with sinus problems or whether I'm doing it for an approach to the sphenoid sinus for pituitary surgery, doing that dissection around the olfactory epithelium so that there is no injury to the olfactory epithelium and thereby preserving the sense of smell. And with these considerations in mind, essentially, we find that there is no increased risk of decreased sense of smell. Other studies that have looked at difference makers with respect to decreased sense of smell have, to echo Dr. Andrews' point from earlier, have found that a collaborative approach with neurosurgeons and a rhinologist, a sinus surgeon, someone who specializes just in sinus surgery, doing the surgery together improves olfactory function after pituitary surgery. This figure simply shows scores on various tests that can be done to measure changes in sense of smell, showing that patients who have surgery with a neurosurgery and ENT team generally have much better outcomes and much less change in their sense of smell after pituitary surgery. When we think of sinus-specific outcomes, we're thinking about sinonasal symptomatology. Again, crusting, blockage in the nose, drainage, facial pressure, and sense of smell. And really this boils down to also some combination of the functionality of the sinuses as well as what impact it ultimately has on quality of life. Because at the end of the day, sinus disease is not necessarily dangerous per se, but it will have such a negative impact on one's quality of life. It is important to pay attention to these factors. So Just to touch on endoscopic sinus surgery again, this has been performed now for over 30 years for patients with chronic sinus disease. Typically, the goal is essentially to open the sinuses. So this is a CAT scan of someone before sinus surgery compared to a CAT scan after sinus surgery, where you can see that these cheek sinuses, the maxillary sinuses, are now open and can easily drain into the nose. These sinuses next to the eyes, called the ethmoid sinuses, are nice and wide open. They drain into the nose. These sinuses are nice and open, but at the same time, we're preserving the function of the sinus because the sinuses drain, and we want to preserve those openings in the right spot so they can drain adequately. And this is just another example, except of an endoscopic view. This is a patient who has a big polyp growing under that middle turbinate, and after the sinus surgery, that polyp is gone, and we can see all the way up to the skull base where those sinuses have been cleaned out, and over here we can see a nice opening into that cheek sinus, into that maxillary sinus. So when we talk about preservation of the sinus function, again, the function of the sinuses is essentially to drain mucus that is produced within the sinuses. We refer to this as mucociliary clearance. This is derived from the fact that the lining of the sinuses have these tiny little hairs that sweep the mucus towards the natural opening of the sinuses, and they prevent the accumulation of mucus and debris within the sinuses. When we do sinus surgery, we really want to maintain the ability of the sinus to drain in the appropriate and natural physiologic way. When there is a disruption of the sinonasal function, and this can be due to a loss of mucosa, exposed bone in the sinuses afterwards, or alterations in airflow dynamics, that mucus can thicken and it can harden and it can become crusts and that sit in the sinuses and do not adequately drain. And then as a result, people can get secondary bacterial infections, typically with a bacteria called staph that many of us have heard of. What we found over time as difference makers with respect to reducing crusting after the surgery is doing a very careful, what I typically refer to, many refer to as mucosal sparing surgery, not just tearing out the mucosa of the sinuses, but doing a very delicate dissection of the sinuses to preserve that mucosa, to minimize the exposed bone that may occur when you take that mucosa out, to minimize the alterations of the anatomy. So we want to preserve that anatomy as much as possible so that the airflow dynamics through the nose remain as close to natural and physiologic as possible. And then post-operatively, there are things that we can do to improve outcomes as well. For example, saline sprays, the use of intranasal saline after the surgery also helps to reduce some of these crusting complications. Another complication that can occur after sinus surgery includes scarring. We know from various studies that scarring is associated with more extensive surgery in the sinuses, but also allowing areas, abutting areas of mucosal injury to sort of come together and stick together during the healing process that promotes scarring. The consequences of scarring include sinonasal symptoms such as nasal blockage, and when that scarring occurs at those natural openings where we want those openings to be to preserve sinus function, it can lead to both recurrent as well as chronic sinusitis. Difference makers with respect to scarring, really it boils down to meticulous surgery. So again, doing the surgery in a way where, and being cognizant of the fact that you don't want abutting and neighboring areas of mucosal injury that could scar together, of taking what some have described as a modular approach, really a very patient-specific, patient-centered, patient-focused approach to the surgery, where rather than approaching the sinus surgery, that approach to the pituitary in a one-size-fits-all manner, you really do that approach in a manner that is specific to the needs of that patient and what they're going to need for their surgery. Additionally, post-operative care and careful consideration and attention to post-operative care really reduces the risk of scarring. So we know this in terms of post-operative care from extensive experience with endoscopic sinus surgery, which again, as described has been around for well over 30 years now. And we know, for example, that intranasal saline is associated with less post-operative scarring. And this is why even after a standard sinus surgery, we have our patients use intranasal saline to reduce that risk. We also know, again, not just scarring, but intranasal saline is going to help with post-operative symptoms, that blockage that patients can get. And what's interesting is it seems that this is in particular true for patients with mild disease. And if there's any reflection of our pituitary patients, it would be patients who essentially have no disease. So this is the mildest of the mild disease. So this is why, especially after a pituitary surgery, this post-operative care is even more important, because our pituitary patients come in with essentially no sinonasal symptoms, and we want to keep it that way. And this is why post-operative care is so important. Disruption of sinonasal function can also lead to chronic rhinosinusitis. This is described and defined by the presence of at least 2 out of these 4 cardinal symptoms of nasal obstruction, drainage, facial pain or pressure, as well as decreased sense of smell for greater than 12 continuous weeks. Again, I'm biased because I treat this disease all the time. I study this disease. I've done extensive research on this disease and quality of life with respect to sinonasal disorders and sinonasal surgery. And I can tell you that these patients experience significant decreases in their quality of life, which is why if a patient does not have chronic sinusitis, we want to perform the surgery in a way that absolutely minimizes the chances of anyone developing this afterwards. So when chronic sinusitis happens after skull-based surgery, for example, pituitary surgery, it is typically a late delayed complication. And again, the risk factors for this include the surgical approach, the extent of the surgery, whether scarring occurs or whether you're left with abnormal anatomy behind. If you do that surgery in a non-mucosal sparing way, and you have a lot of exposed bone, that is a setup for developing often low-grade osteomyelitis, where there's chronic inflammation and infection of that exposed bone, which leads to scarring, crusting, and bacterial overgrowth that then stimulates this chronic inflammation in the sinuses. Post-operative radiation is also a risk factor for development of chronic sinusitis, and this is why, in particular, for our patients who are going to be irradiated, both before as well as after the radiation, we perform meticulous care of the sinuses to minimize the chances of any kind of sinonasal complications. A number of studies have been performed looking at differences in terms of surgical approach, looking at some of the older approaches, for example, sublabial approaches to the microscopic approach, to the endoscopic approach. And what we found is, in general, patients who have had endoscopic pituitary surgery have improved sinus function, whether it's a matter of needing sinus treatments, needing sinus medications, both intranasal, topical, as well as systemic medications. Patients who have endoscopic pituitary surgery generally have much better sinus function afterwards. And this directly translates to improved sinonasal quality of life after endoscopic pituitary surgery, as opposed to some of the other techniques, whether it's transnasal, microscopic, or sublabial. We also know that more extensive skull-based surgery is associated with greater symptomatology. As I mentioned before, it's a risk factor for development of scarring, but it's also a risk factor for having greater sinonasal symptomatology as well after the surgery. And this is why we strongly advocate for a very patient-specific, patient-focused, patient-centered approach to the surgery. Only doing the surgery that the patient needs. Again, not taking a one-size-fits-all approach, and really just doing that minimal surgery that gives our neurosurgical colleagues optimal exposure, but just that optimal exposure and nothing more, so that they can do the surgery in a safe manner. So bottom line is, when it comes to sinonasal difference makers, we're talking about a collaborative, multidisciplinary team having not just neurosurgical expertise to take that tumor up, but also rhinologic expertise. Individuals who specialize just in sinus surgery, again, whose careers and practices are focused on that, as this translates to the pituitary surgery as well. Bottom line is the more that you do something, the better you are at it. And then again, taking conservative patient-tailored surgery, making patient-tailored surgeries that are suited exactly to the needs of the patients. Doing meticulous surgical dissection during that approach to avoid not just the olfactory nerves, but again, doing the surgery in a way that minimizes changes to the anatomy, as well as doing meticulous post-operative care, which in my opinion, again, this may be the bias of a rhinologist, the post-operative care is almost as important as the surgery itself, because that post-operative care is gonna lead to avoidance of so many of the long-term sinonasal complications.
So we're coming towards the end of the presentation and really getting to our conclusions, and we hope to have hit the point that rather than try to fit the patient to your one and only way of doing things, having all the different elements that could be involved in the care of a patient to fit that to the patient's need, really, we believe that that makes a difference. Tumors in the pituitary gland are not just a simple condition that can be treated with a procedure, and that exceeds what the slide says, a well-executed surgery. And as they well say, the devil is in the details. And so anybody can do pituitary surgery nowadays, even with the endoscope. However, there's all the other things that surround the procedure itself that contribute to the outcome and therefore make a difference. And so we live for what we preach, and so we treat our patients in a multidisciplinary fashion, in a way that we can adjust all the things that we have to offer to the different needs that the patients have. And so having talented endocrinologists, a very talented rhinology surgeon like I have here sitting next to me, really makes not only my life, but the patient's life, which is more important, easier. Having radiation oncologists that can help treat the patients that we cannot treat. Having all the other services, such as specialists who can treat headaches, specialists that can do visual rehabilitation, having good neuro-ophthalmologists really does make a difference. And as such, we believe that having a team that is focused on the patient rather than a patient that needs to go look for his own solutions does make a difference. And I think with this, we're going to leave some time for the questions. This is a view of our neuroscience center and our academic center. And this is, if you have any questions, certainly you can reach us at this ways of contact. And we're going to turn over to Danielle, I believe, so we can answer any questions that the audience may have.
Okay, thank you so much for such a thorough and amazing presentation. We don't have any questions, we just have comments. Excellent presentation. So I think you covered everything so well that we don't have any questions tonight. So that will conclude our webinar today, and we appreciate you taking the time to join us. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website, www.pituitary.org, after it is edited. And we hope that you have a great rest of your evening.
All right. Well, thank you very much and have a good night. Thanks again for the opportunity.
Thank you very much.
Bye.
Bye.